Welcome to today's webinar, Diagnosis and Management of Pediatric Ataxia. Please note that all attendees are in listen-only mode and that this webinar is being recorded. I'm Lori Sjogren, Community Program and Services Director for the National Ataxia Foundation, and I'll be facilitating today's webinar. Questions for the webinar speakers can be typed in the Questions tab found in your control panel. We will answer as many questions as time allows prior to the end time of today's session. We will have a record of all questions asked and will respond to any unanswered questions. So now I'd like to introduce the speakers for today's webinar. Our first speaker, Dr. Kristen Baranano, has been part of the Johns Hopkins Ataxia Center since 2013 and has recently established a multidisciplinary pediatric ataxia and cerebellar disorders clinic at the Krieger Institute. Our next speaker, Dr. Eric Chin, who is completing a combined residency and fellowship in pediatrics, child neurology, and neurodevelopmental disabilities at the Krieger Institute. Dr. Baranano will start out our webinar today. Welcome, Dr. Baranano.
Again, I'm Kristen Bargnano. I'm a child neurologist and neurogeneticist. I'm based at Johns Hopkins in Baltimore, Maryland. I also am part of the Krieger Institute, which is affiliated with Hopkins. And so today, it's my great pleasure to talk with you about the diagnosis and management of pediatric ataxia. So I've organized this webinar as a series of questions that are frequent questions that parents ask trying to understand their child's neurologic issues. And so the first question that we typically ask is, well, what is ataxia? So ataxia is incoordination not due to muscle weakness. And it can be very challenging to diagnose in children because it occurs in the setting of developmentally appropriate incoordination. So what does ataxia look like? There is what we call gait ataxia, which if you think of a toddler who's just starting to walk, they have a drunken wide-based gait, like a drunken sailor. And that typically as the nervous system matures, people develop a narrow-based gait. But then with ataxia, then that gait can become wide-based again. We also describe what we call dysmetria, which is difficulty for reaching for items or for feeding themselves. Sometimes this is described almost as a tremor. And when the neurologist is testing the finger, nose, finger testing, this is what we're looking for is dysmetria. With dysarthria, it's unclear speech, issues with enunciation. With the involvement of the cerebellum in our speech patterns, it's important for making our sounds crisp and also for the pattern of our speech. So sometimes when kids have a cerebellar reason for dysarthria, they'll also have what we call scanning or halting speech. And then finally, the cerebellum is also involved in control of eye movements. And so with ataxia, we sometimes see what we call nystagmus, which is a jerking or jiggling of the eye movements, which can be something that children don't even notice, or sometimes it can interfere with their functional vision. So what should I do if I suspect my child has ataxia? Well, sudden onset of ataxia is an emergency. One of the most common reasons why kids would acutely become ataxic is because of an accidental ingestion. And so children who have sudden onset of ataxia should be evaluated in the emergency department. And that's one of the first things that the emergency department doctors will be looking for, is whether there might have been any substances in the home that could have prompted this symptom. Once that relatively common reason is excluded, there are a host of other reasons, and typically the investigations would include lab work, typically an MRI of the brain or spinal cord, and possibly even what we call a lumbar puncture or a spinal tap to sample the spinal fluid, looking for signs of inflammation or infection. So then what are some common causes of ataxia in the emergency department other than ingestions? Well, unfortunately, we sometimes find brain tumors this way, especially if a tumor is in the part of the brain called the posterior fossa where the cerebellum lives. Those children can present with relatively subacute over days or weeks of developing of ataxia. So that's one of the major things we rule out in the emergency department. Unfortunately, just like adults, children can have strokes. Those strokes can either be what we call ischemic or hemorrhagic. An ischemic stroke is because there's a clot that's blocking the flow of blood to a part of the brain, or sometimes there can be a hemorrhage where there's actually bleeding into part of the brain. So that's something that we would exclude typically by an MRI. We also sometimes see what we call demyelinating events. And so myelin is the coating of the nerve fibers in our nervous system, which allows impulses to be conducted quickly and accurately. And sometimes there are conditions where there's inflammation or the body's own nervous system attacks the myelin. And so these conditions include something called ADEM, which is ADEM, acute disseminated encephalomyelitis, or conditions, something called Guillain-Barré syndrome, and there are variants of Guillain-Barré that can present with ataxia. Especially if there is concern for a fever, we'll be thinking about infections in the nervous system, and specifically when an infection attacks the cerebellum, we call it cerebellitis. And then there's a big category of post-infectious causes of ataxia where the immune system gets revved up by an infection and there's cross-reactivity where our own antibodies start attacking parts of our nervous system, causing post-infectious neurologic symptoms. So what are some common causes of cerebellitis? Well, one of the most common things is an organism called Bartonella that causes something called cat scratch fever. There's a common infection called Mycoplasma pneumoniae that seems to present just like a common cold, but that can sometimes cause cerebellitis. And then a very common virus called Epstein-Barr virus that causes mononucleosis. So then we talk about what is acute cerebellar ataxia. And so acute cerebellar ataxia is pretty much a diagnosis of exclusion where we believe that there's been a post-viral process that is causing ataxia. And this is the most common cause of ataxia in childhood. And it's typically in young children, usually between 2 to 4 years of age, although typically can be seen up to the age of 6. And we think of this as being an autoimmune phenomenon, meaning that our own bodies are producing antibodies that are cross-reacting with the cerebellum. Usually in the days or weeks before the onset of the acute cerebellar ataxia, there will be a history of some kind of infection, but not always. And actually, chickenpox or varicella actually used to be a very common and actually the most frequent cause of acute cerebellar ataxia. Up to 1 in 5,000 cases of routine childhood chickenpox would cause cerebellitis. And so we see this much less frequently now. It's very, very rare to see a case of acute cerebellar ataxia after the varicella vaccine. But in general, most cases are still post-viral. So the question then is, what happens next if my child continues to have ataxia? Well, acute cerebellar ataxia, this post-viral entity, typically resolves in a few weeks. And so if ataxia is persisting beyond 2 to 3 weeks, this really means that it needs further investigation and it may really not be just a post-viral syndrome. So for example, one rare but very treatable cause that we're always on the lookout for is something called opsoclonus myoclonus syndrome, or OMS. And this is also an antibody-mediated phenomenon. About half the time it can be associated with a childhood cancer called neuroblastoma. And the tumor can be very small and difficult to find, but it produces these antibodies that cross-react with the nervous system. It requires recognition of finding that tumor if it's there, and even if there's not any tumor, very aggressive treatment in terms of modifying or modulating our immune system with medications like very high-dose steroids, infusions of something called immune globulin or IVIG, and even some medications, something called rituximab to affect our B cells. But it's very important to recognize this entity. There's often a delay in recognizing it, and children have much better outcomes when it's treated earlier and aggressively. So what about my child who has episodes of ataxia? There are some children who will have episodes of ataxia where they seem to have unsteady gait that lasts minutes to hours to even days, and then may go completely back to their baseline in between episodes. So we know that in this situation, migraine-related phenomenon are relatively common. Migraines can have very funny symptoms associated with them. People who have heard of migraine auras can hear about things like visual changes like sparkles or squiggles, or what we call scotomas, where parts of the eye where the vision are blurred. Some people will have numbness and tingling associated with this, or even be weak on one side of their body. And some people will have symptoms related to vertigo or ataxia associated with their migraines. One of the most common migraine variants in young children is something called benign paroxysmal vertigo of childhood. Children, when they are acutely ataxic and unsteady, will complain sometimes of being dizzy. They'll look pale and unwell, but they don't typically complain of headaches. Then there's also more typical vertiginous migraines, where people will have the illusion of movement and feel dizzy and can have unsteady or ataxic gait and may or may not have an actual headache associated with it. But for those children who are having episodes of gait ataxia with or without some of these other symptoms, we typically recommend that they have a battery of blood and urine studies during an episode, because there are some rare inborn errors of metabolism that when a child is symptomatic, we can detect markers of the disorder in their blood or their urine. After this has been done, if we don't have an answer, we then consider something we call the episodic ataxias. They go by names like EA1 and EA2, and there's typically genetic testing for these disorders. Well, then the question is, well, what about my child who's always had ataxia or has developed it very gradually? So the first thing I would recommend is having your child evaluated by a neurologist who's familiar with ataxia. In general, ataxia is a fairly rare diagnosis, and so it's important to be seen by somebody who has some familiarity with it. Typically, children will have to undergo a brain and sometimes a spinal cord MRI. So an MRI is a big magnet. There's no radiation exposure, but typically, especially with young children, kids will have to undergo sedation or general anesthesia for this, so it becomes a somewhat big procedure to do this. Next would be some blood and urine studies to screen for some treatable causes of ataxia that we'll touch on in a moment, where there are some ataxias that have laboratory markers where we can measure circulating substances in the blood or the urine that give us clues in terms of the cause of the ataxia. In general, it's important, but sometimes challenging to distinguish between what we would call the primary ataxias and disorders with ataxia as a symptom. So there are a number of disorders that we don't think of as being primarily pure ataxias, but ataxias can be a symptom. For example, there are a class of disorders called leukodystrophies or white matter diseases that can present with ataxia, and so it's have to take into the big picture in terms of if there are other symptoms associated or other imaging findings on the MRI that might point to that direction. But if we don't have an answer at this point, the next step is likely going to be genetic testing. So what are some of the genetic causes of ataxia? Well, so when we talk about our genes and our genetic information, our DNA, we have about 20,000 genes, and each gene is the individual unit of information. And we have two sets of all of our genes, one set inherited from our mother and one set inherited from our father. And so there are some disorders where if you have a change in just one copy, it's sufficient to cause the disorder. And these are what we call autosomal dominant disorders. So when we talk about our autosomal dominant ataxias, there are a couple different ways that genes can be changed. So when we look at the actual spelling of the genes, the letters, the A, C, T's, and G's that spell out our genetic code, there are some genes that are common to have what we call triplet repeats. These repeats of generally CAG, CAG, CAG that are supposed to happen a certain number of times. Sometimes if these triplet repeats expand and become more numerous, it can cause the gene to have dysfunction and cause our ataxia. And these are some of our more common, what we call spinocerebellar ataxias, like SCA1, SCA2, SCA3, and SCA7. With our triplet repeat expansions, oftentimes there's a family history that this is running in a family because an affected parent, every time they have a child, will have a 50% chance of passing this along to their child. However, many of these disorders also display what we call anticipation, meaning that the triplet repeats can become a longer or more problematic from one generation to the next. And so sometimes the age of onset will be much lower in the child, and a parent may not even realize yet that they're going to be affected by the disorder, even though they carry the same gene change. The other type of change that we can see are what we call conventional mutations, which are more just kind of changes in the spelling of the DNA. And these are things like SCA5, SCA13, and SCA29. But again, these are autosomal dominant disorders, meaning the child has the disorder because they have a change just on one copy of the gene. But it's not uncommon in this situation that the change is what we call de novo, or brand new in the child, and that there's not a family history of the disorder. So in contrast to autosomal dominant disorders, we also have what we call autosomal recessive disorders. And these are the classes of the different ataxias where you're only affected if you have changes on both copies of your gene. So one of the most common ataxias in childhood is actually Friedreich's ataxia, and that is also a triplet repeat expansion, but you have to have the triplet repeat on both copies of the gene to be affected. And then in terms of examples of some other of the autosomal recessive ataxias, there's, for example, ataxia telangiectasia, ataxia with oculomotor apraxias type 1 and 2, RSACs, and the list is very numerous in terms of autosomal recessive ataxias. So in terms of what are the most common genetic causes of ataxia in childhood, again, Friedreich's is the most common. And for you, when you look at children who have onset of ataxia before the age of 25, 75% of the time the answer is going to be Friedreich's. One of the other more common ones is going to be ataxia telangiectasia, or AT. And so while there are many different causes of ataxias and hereditary ataxias in childhood, all the other ones individually are quite rare and may account for something like 1 to 2% of all the cases of childhood ataxia. And so that can make it very challenging to learn more about your child's disorder when you have one of these very rare causes of ataxia. So what are some of the genetic tests that might be sent when we get to this point? Well, so sometimes we are able to do just single gene testing. So if a child has a presentation that's very consistent with, for example, Friedreich ataxia, or if they have a marker in their blood like an elevated AFP that you would see in ataxia telangiectasia, we may just send single gene testing. Sometimes we'll send a panel of genes that might have 10, 20, hundreds of genes on it, especially if the family history suggests that there might be a triplet repeat expansion going on, because those have to specifically be tested for, and we can't necessarily pick up those triplet repeat expansions on our more typical sequencing technology. When we're taking a bigger look at all of the different types of changes that there could be, we have the ability to do what's called next generation sequencing, where we can quickly and relatively inexpensively sequence actually all of our genes at the same time, all 20,000 of them. And so when we look at all 20,000 of our genes, we are looking at what we call whole exome sequencing, which is when we look at that part of the gene that actually gets turned into the protein, and not necessarily looking at the spacer or regulatory information. If we're looking just at the subset of genes that are known at this point in time to be associated with ataxia, then that panel is typically called an ataxia exome. Whole genome sequencing is just now starting to come into clinical use. It's being more used on a research basis, but whole genome sequencing actually does look at that spacer and regulatory information, and sometimes will give us the answer when we can't find it through whole exome sequencing. If we're strongly suspicious that a child has a genetic cause for their ataxia and we haven't gotten an answer, we will typically also pursue what's called a chromosomal microarray. And so a chromosomal microarray is a test that looks not at the spelling changes, but if there are any extra or missing pieces of information. And especially if a child has significant developmental delays early on, this may actually be the first test that we order. So the big picture question is, why does it matter what kind of ataxia my child has? Well, first off, we want to know if there's a disorder-specific treatment, and we'll touch on that in just a moment, that there are some disorders that have specific treatments that really can impact the course of the ataxia. We also want to know what the future holds in terms of how quickly or how slowly the ataxia may progress, if there will be any other associated issues that go hand in hand with the ataxia, things like cognitive decline or seizures or other medical issues. We know that having a specific diagnosis may help with getting services and help with arguing with insurance companies about why things should be covered. It is also going to be key for eligibility for clinical trials. You know, ataxia is a very what we call heterogeneous group of disorders. There are many different reasons for ataxia and many different things going on in the downstream and on a molecular level. And to really target interventions, it's going to be important to have, you know, as individualized a therapy as possible based on the gene that has the change. And then also there's a lot of power in the support of other families who understand what children and their families are going through when they have a diagnosis of ataxia. So here we are, it's what are some examples of ataxias that have specific treatments. So for some of our episodic ataxias, they actually respond to treatment with a medication called acetazolamide or Diamox, and then also a medication called 4-aminopyridine. And so these medications can really help greatly reduce the frequency and severity of the attacks that happen with these episodic ataxias. There can also be vitamin deficiencies. Some of these can be deficiencies that can just especially be seen in older individuals because of nutritional issues or things like pernicious anemia. But there is a genetic ataxia associated with deficiency of vitamin E that we don't ever want to miss because it can be very effectively treated by supplementation with vitamin E. There are a group of disorders that have something called coenzyme Q10 deficiency. And so unfortunately, this isn't something we can typically diagnose just by measuring coenzyme Q10 in the circulating blood. So we have to either diagnose this based on a muscle biopsy and measuring coenzyme Q10 levels in the muscle biopsy, or by finding the genetic changes associated with this. So until someone has a definitive diagnosis, it's not uncommon for them to be recommended to take some of these vitamin supplements until we firm up what the diagnosis is. There is an entity of gluten ataxia that we give consideration to. This is associated with celiac disease or the antibodies against gluten. And so typically treatment for this would be removing gluten from the diet. There is a disorder called GLUT1 deficiency, where the transporter that helps bring sugar into the nervous system is deficient, and we can bypass this transporter by something called the ketogenic diet, which is a very high-fat, low-carbohydrate diet that provides an alternative fuel source to the brain. There's a disorder called CTX, or cerebrotendinous xanthomatosis, that we can treat with chenodeoxycholic acid. And then we have a whole group of what we call mitochondrial disorders that may be amenable to different therapies and interventions. And so the mitochondria are the cellular organelle in our cells. We have hundreds of them per cell that are responsible for producing the bulk of our cellular energy. And when the mitochondria are having dysfunction, the tissues that have very high energy requirements, like the nervous system, for example, can have dysfunction. And so we oftentimes employ strategies to provide certain supplements like coenzyme Q10 and carnitine and other cofactors that we feel may help the mitochondria work more effectively to help address some of these symptoms. There's also a disorder called Niemann-Pick C. That's one of these bigger syndromes that oftentimes presents with ataxia, but that is something that's amenable to treatment to intervene with a medication called miglustat, and then there are also trials with something called cyclodextran as something that may be helpful. So what do I do if my child doesn't have a diagnosis? And unfortunately, in my experience, this is the case about half the time. So I think, you know, at any given time, we're good at getting diagnosis for about half of children, but for other kids, it remains elusive. So in the meantime, we will always periodically revisit the genetic and other evaluations to try and come up with an answer. But in the meantime, what we do is we treat the symptoms and any associated issues, and I'll touch on that again in a moment. Kids will typically be getting therapies like PT, OT, and speech. And we oftentimes will want our children to have neuropsychological testing to really figure out their cognitive strengths and weaknesses, because we know that sometimes learning problems or even intellectual issues can go along with ataxia. And then Dr. Chin will be talking about school accommodations in terms of something being an important piece to help kids with ataxia succeed. So what medications have been tried for ataxia? So there have been lots and lots of different medications that people have theorized may be helpful in terms of thinking about how they function in the cerebellum and may improve the firing of those neurons. And this is the names of some of the medications that people have tried or are trying in trials. And unfortunately, none of them are really have any overwhelmingly robust effects. And some of this may be the fact that these studies are done with a mixed population of reasons for ataxia, which doesn't preclude that a certain subtype of ataxia may be more responsive to one of these medications versus another. Okay, so what therapies are on the horizon? Well, in terms of things that we are getting excited about that are really, going to be coming down the pike in the next couple of years, is we know, especially for those spinocerebellar ataxias that have the triplet nucleotide repeat expansions, that these are going to potentially be amenable to what's called antisense oligonucleotide therapies, where these small molecules can be infused into the nervous system and can help downregulate the production of these abnormal gene products. And so that's something especially that's being looked at in mouse models and looks very, very promising. And we're hoping in the next few years will be a potential for clinical trials in humans. Regardless of having the specific gene or genetic diagnosis, we do know that especially many of the autosomal recessive ataxias, even though they're very different genes, they all seem to converge on similar downstream pathways, including things like mitochondrial dysfunction, impaired DNA repair, and lipid metabolism. And so targeting some of these shared metabolic pathways may be a way to help with some of these ataxia and with these symptoms. So the question then is, what are some of the common associated symptoms and how do we target these? So of course we're talking about truncal instability that goes along with the gait instability. And so with truncal instability and unsteady gait, we place a lot of emphasis on doing physical therapy. We know that when we exercise those circuits to help fine-tune our coordination skills, we can help strengthen the way these brain cells talk to each other and can see definite improvements in our coordination and in our fine motor skills for sure. We also want to emphasize things like core strengthening to help with stability, and these are exercises like swimming, horseback riding, martial arts, things that really engage those core muscles. Some children will also have significant issues with spasticity related to their diagnosis of ataxia. We also address that with physical therapy, with stretching, but sometimes we have to use some of the medications in our toolkit to help relax the muscles, things like Valium and baclofen, sometimes even things like Botox injections. Some of our ataxia disorders have associated neuropathy with them, where the nerves that supply things like vibration and position sense aren't working well, and that can make the incoordination even worse because you're not getting that kind of sensory input. And so that's something we have to be aware of. Some children do have seizures as part of their ataxia disorder, and those are typically treated by more conventional anti-seizure medications. A lot of our kids will have speech and feeding difficulties, and so we have to be attentive to this to make sure that kids are swallowing safely. So kids may undergo swallow studies to make sure that they don't need to change their consistency of foods. And then also, as speech becomes more difficult to understand, referring kids for what we call adaptive technologies, so they can use things like iPads and the like to be able to communicate if they're having trouble doing so verbally. We know that with many of our kids with ataxia, fatigue is a huge issue. And one way of thinking about this is that we have a certain pot of energy in the course of a day, and when our nervous system isn't working optimally, it takes a lot more energy to do things that would be a lot easier for someone without a neurologic issue. And so sometimes we address fatigue by certain accommodations at school and at home. Sometimes in conjunction, it's very common to have attention and mood issues. Sometimes we help deal with that with medications like stimulant medications that might be used to treat ADHD. And then again, learning disabilities are super common. And I think that'll help us transition into Dr. Chin's talk about school accommodations. How can I reach you with questions? So I am very happy to hear from anyone through my email, which is there. And I'm also have joined the Facebook group of the parents with kids with ataxia. If you have a question that you'd like my input on, please feel free to just tag me so I know that you'd like some input from me, and I will do my very best to help address questions there.
All right, now we're going to turn it over to Dr. Chin.
Okay, great. So I'm one of the neurodevelopmental disabilities fellows. So I work with children with a variety of different needs, ranging from kids with ADHD and problems with attention to children with movement disorders such as ataxias, to children with more significant learning difficulties. And so I'm going to give a little bit of a high-level overview to school and services for families, and just kind of a brief discussion of what kinds of services are out there, and the process for getting an appropriate school placement for her children with ataxia. So my objectives for today are here to talk about that spectrum of therapies and services, the general rights under U.S. law, and what kind of process and recourse families have for getting the right combination of therapies and services. So just to begin with, I want to acknowledge that no two children with ataxia are alike. And what do I mean by that? So Dr. Barignano has given us an idea that there are a huge number of diagnoses that can go into producing an ataxia. But even within that, children can have ataxia at all different ages. Children can have problems with, as she mentioned, attention, learning difficulties, depending on the diagnosis and the individual child. So really, planning for her school really has to kind of account for all of these things. And so, and then thinking about what kinds of school processes are the most effective for helping someone learn the best they can in a school setting. We tend to think of along different kind of functional directions. So in terms of gross motor functioning, how well is someone able to walk or run or climb? And that goes into things like transportation to school, getting from class to class. We look at fine motor functioning, things like writing, typing, cutting, pasting. And so how well is a child able to use her hands in really fine, coordinated ways? That can be a particular challenge in children with ataxia. How well are her children able to use their speech and language communication skills, and really express what they know and understand, and really, and how well are they able to understand when someone else is communicating to them, and then kind of core cognitive abilities, and are there challenges in thinking and learning it themselves? So all of these differences impact what services may be needed to learn to a child's best ability in the school setting. So what kinds of services are there here within the school system for supporting learning? So one of the core pieces of this is special education, and I'll go into that more in detail in a little bit. But special education is not just target individualized teaching, but then also the process of monitoring, consultation with experts is needed, collaboration between educators and therapists and medical professionals. And then looking at additional resources for education as needed. And reaching outside of direct education and therapy and other resources may also be very helpful to directly enabling participation in the classroom. So again, speech and language therapy may be very important. And occupational therapy can be helpful for fine motor and self-care type of skills. Physical therapy, as Dr. Barignano mentioned, can be very helpful for optimizing the walking, running, transportation, and types of concerns. And all of these kinds of, and for some children, all of these services may be needed and really have to work together well to really give the best outcomes. So what are families' rights under U.S. law? And since the 70s, there's now a solid chain of legal precedent reaching from the courts to the legislatures. Here's in federal law, and it's now well established as a principle that all children, and regardless of physical, mental, emotional disability, in the U.S. are entitled to a free and appropriate public education. And states are actually federally required to create plans and set targets for children to meet. So there are two main mechanisms for accessing the school-based services. And the two laws that I'm going to talk about are the Rehabilitation Act and the Individuals with Disabilities Education Improvement Act. So the first column there, the 504, or Section 504 of the Rehabilitation Act. You may have heard the term 504 plan, 504 accommodations. This is the more broad of the two mechanisms, and this applies to anybody, adult or child, with a disability. And disability in the law here is defined as any person who has or has had a physical, mental, or mental impairment, which substantially limits one or more major life activities. So this is very broad. And what is a person entitled to with a disability? So when engaging with any institution that's federally funded, so in this case, for the most part, the school system, a person is entitled to a reasonable accommodation. And so, or in other words, reasonable steps to accommodate the disability unless it would cause undue hardship to the school. And this is enforced by the Office for Civil Rights. So this is a general civil right that's available to people in the general population, and I'll go into more detail in some subsequent slides and what these kinds of reasonable accommodations, what that can look like. So going into more depth into the IDEA law, this one's a little bit more targeted, and so really we're looking for children who fall into 13 specified disability categories. And again, I'll go into that in a little more detail. And then there's specific state and federal requirements for who actually qualifies for special education and related services after appropriate evaluation. And so under these more strict categories, the school is obliged to, if a child meets these criteria, construct an individualized education program. And that's more of what I was talking about in the previous slides, if more kind of intensive supports are needed. And that's regulated through the Federal Office of Special Education Programs and through the state agencies. So going into a little more detail, what do accommodations under Section 504 look like? And these are really kind of customized around individual needs. So for example, if a child's having difficulty completing assigned work, then a reasonable accommodation can be to allow extra time in the classroom, to shorten assignments or work periods, to simplify. And if a child's having difficulty paying attention and keeping up with complex instructions, there can be an arrangement to simplify complex directions or break instructions into smaller parts. If a concern is more motor based and transportation related, then maybe getting to the back of the bus is a difficult challenge for a child. Then maybe a reasonable accommodation can be something as simple as providing seating at the front of the classroom at the front of the bus. So a lot of these are kind of arranged on a case-by-case basis, but there's a solid framework for this, and even something as simple as Googling 504 accommodations for a certain challenge, you can get a pretty good idea of what kinds of accommodations have been made by school systems in the past, and that's also something you can discuss with schools, with pediatricians, with therapists. So moving on to the IEP framework. So again, this is individualized education. So the 13 qualifying categories are on the left side there, and that ranges from autism, intellectual disability, to more medical diagnoses such as traumatic brain injury, visual impairment, orthopedic impairments. And so it's a wide range of diagnoses that end up qualifying for an IEP, and there are actually some non-specific categories such as other health impairment that may also capture things that aren't neatly fitting into one category or another. So in terms of the actual process of obtaining an IEP, the school system has an obligation to be monitoring for her difficulties learning in the classroom. So educators, therapists within the school system may initiate the referrals, but parents also have the ability to initiate referrals by making a request in writing to the school system. So everything begins with that initial referral. So once a referral is placed by anybody, educator, parent, and therapist, the school has up to 15 days to set up a meeting and obtain family consent to begin an evaluation. So what entails an appropriate evaluation depends on a case-to-case basis, but there are regulations on the federal and state levels in terms of what an appropriate evaluation means. So if there are cognitive concerns, then the school may actually perform some of the psychoeducational testing that Dr. Barignano who mentioned. They may perform detailed speech language assessments, occupational therapy assessments, and see kind of what are the child's skills, what are the kind of gaps that are preventing appropriate learning. So this evaluation, so the school by law has up to 45 school days. Let me correct for both of those time windows to perform that evaluation and then to come to a final determination. And the determination is first kind of an up or down, yes or no. Is there an eligibility for services? And if there's an eligibility for services, what are the kind of needs in terms of specific services? And so the family is invited to meet with the school, and the results of that evaluation are discussed, and that plan is put into place. So once that plan is put into place, then there's a requirement for periodic review of goals and services at least annually, and then a full reevaluation in every 3 years. So in terms of the intensity of services, one principle guiding special education in the United States is the principle of the least restrictive environment. So what that means is that to the degree possible, there's an agreement that a child should be placed in the most kind of normalized environment that's possible. So to the degree possible, children should be placed in the typical school environment, and when that's not possible, to get all education that way, then maybe some education can be supplemented within that regular school environment, and then if that's not possible, then specialized placements are considered. And so there's a spectrum of services that really is considered, and it really is kind of optimized over time. Another principle that's important to consider here is that there's kind of a trial that I talked about. There's kind of a continual reassessment. So response to intervention is another principle that this is guided by. Really, the school system is guided by seeing difficulties even after interventions, and that should be a prompt for the school system to reevaluate and make adjustments as needed, and whether that's increasing the level of support or changing the supports that they're providing. That should be another guiding principle there. So what happens if the system's not working as expected, whether the school's not following through as they should be, whether the program's not as successful as everybody hoped? So the first step is, again, to engage in the process and talk with the other members of the IEP team, the educators, the therapists, and potentially to request reevaluation, and maybe a diagnosis is being missed, or the level of functioning is not quite where everybody thinks it is. And failing that, then on a local basis, there are educational advocates and legal advocates who are available to help sit in on meetings and encourage the school system to follow through with evaluations and providing resources as necessary. Unfortunately, that, like I mentioned, this is local. This is not standardized across the country, so this can take some searching on a local basis. And I've listed some resources that can give you a starting point if you're having trouble finding these kinds of resources. The Kennedy Krieger Resource Finder is one resource that can help you who collaboratively look for these resources in your locality. And I'm also happy to take questions.
Great information on school accommodations. We'll now open up the webinar for questions. Turn it over to Dr. Baranano again to answer some of the questions that she has received.
Sure. So I'm just opening up the questions that we had gotten ahead of time. All right. So there was a question. It said, if you could push one mantra to primary care pediatricians about pediatric ataxia patients to aid in appropriate care of this rare disease, what would that mantra be and why? From my perspective, I would love to see patients with ataxia earlier rather than later. I think especially with some of these treatable conditions, we are seeing patients much later than we would be ideal. And so I would love for pediatricians to know more about ataxia and know that they can always pick up the phone and give us a call and tell us about a patient they're worried about. And depending on the situation, we will always expedite getting a kid with a relatively new onset of ataxia into the clinic to be evaluated so we can start the process of figuring out what the cause is, would be what I would want to convey to pediatricians and their level of awareness about that. Let's see. So question is SCA6 always a CAG repeat? So I think I know everybody is very interested in their specific ataxia. And so I'll try, when people are asking about specific ataxias, I'll try and make the answer as generalizable as possible while still answering the question. So when we talk about SCA6, SCA6 is typically a triplet repeat expansion in a particular gene called CACNA1A. But we know that when there's a spelling change in CACNA1A, it can cause episodic ataxia type 2. And so, it seems like that should be very okay. You have a triplet repeat, then you're going to have kind of like a slowly progressive ataxia. But if you have episodic ataxia type 2, you're going to have just episodes of ataxia. But the answer probably lies somewhere in between. So I know personally of at least one patient who had a change that you would have predicted caused an episodic ataxia type presentation, but she's actually behaving more like a spinocerebellar ataxia type 6. So I think what we're coming to recognize is that there probably is a range of how these disorders present, and that, you know, the dogma or what's written in the textbooks may not always be completely correct. Let's see. So here is I presume a mom, a parent, who's talking about their child who had a gene panel. So at 140 gene panel, they came back with 2 variants of uncertain significance. So it sounds like had some difficulty kind of firming up the diagnosis, and had some difficulty with having feeling that they were being adequately supported by their local doctors and kind of their diagnostic odyssey. And so what I would say in this situation is that it is very common to run across, when we're doing genetic testing, very common to run across variants of uncertain significance. And so it requires sometimes a lot of research in trying to understand those variants. Sometimes it requires reaching out to researchers who are like doing basic science at the bench with these genes to try and figure out whether a particular genetic change is really relevant or not. And so what I'd say is, and sometimes it takes just a little bit of time passing for us to learn more about that change and find other patients who have the change to determine if things are really relevant or not. But so what I'd say in a situation like this, I would really encourage the family to reach out to someone at an ataxia center to see if they can review the results, provide some input, provide some guidance. So we're always open to hearing from families, especially when you're trying to get guidance about where to go next and what to do. Let's see. I have a question from the webinar today about ataxia type 27, and their child is very fever sensitive. And so far she's always gone back to her baseline. So, you know, ataxia type 27 is one of our autosomal dominant disorders, and it's caused by a specific gene change in something called FGF14, I believe. And we know, what we know about that is that gene is probably important in regulating sodium channels in the cerebellum. And so I think that has been reported before, that kind of real exquisite sensitivity to fever and being ill can impact the function of the sodium channel gene. So I think that is definitely something that's been appreciated before. And so, but that's always just a general concern with our kids with ataxia, is that it's not uncommon for neurologic symptoms to worsen when kids are acutely ill. And that's always a worry of ours, and making sure that they don't, for example, decompensate when they become ill. Let's see. Eric, have you gotten any questions that you'd like to tackle?
Sure, yeah. So starting with some of the questions I had before the talk, I had a couple questions about specific ataxia, specific genetic diagnoses, and what kinds of school accommodations I had consider. So the tricky thing with working on a diagnosis basis is that that can be both too specific and not specific enough for the school system to handle. And what I mean by that is, so too specific, a lot of these conditions are very rare, so it may very well be the first time that a given school has seen a child with that disorder. So they may not have a good idea how to what to offer her to begin with. And when I say not specific enough, like I mentioned, no two children, even with the same condition, are equivalent in terms of what they may need from a school setting. So even from looking at the example from a fine motor perspective, so two children with the exact same diagnosis, one may do perfectly well and keep up in the classroom in terms of handwriting tasks. One may just take slightly longer to complete assignments, and one may just do much better with an alternative means of communication. So, so the diagnosis really kind of, I would consider a starting point rather than a direct path to deciding what the school services should be for a child. And to flesh that out a little bit, I think medical evaluations, therapy evaluations are really key to giving a much more detailed, fine-grained assessment of what is a child's fine motor skills, communication skills, gross motor skills, depending on what the kind of concerns are. So dovetailing that into some of the questions I'm seeing from the lecture. So there are questions about choking, swallowing, pooling, drooling in the classroom. How do I substantiate or educate teachers on dysarthria and tasks like speech and oral reading? Again, I think really getting the therapist involved in communicating can be helpful there. Speech language therapists would come to mind in terms of really helping come up with concrete suggestions in the classroom, what can be helpful, both in terms of educational plans, but also in terms of what can be helpful from a medical perspective in the classroom. There's a question, do you ever have schools use children's hospital evaluations as part of special education and planning? And I think that can be tricky again, and that's written for a different audience. So it's not necessarily tailored to providing recommendations for helping a child in the school setting. So what I would suggest is that maybe on an outpatient basis, that medical providers or therapists it might be helpful for them to write a letter to the school, really kind of condensing what are the major medical findings that may apply to and impact education, and what some concrete recommendations might be in the school setting. So continuing on that theme, I think focusing on concrete impairments, and then because that's much easier for a school system to understand and work with than necessarily a diagnosis or findings observed in a hospital setting. And I think that applies to some of these other questions also, looking at for specific accommodations in PE or nystagmus. Again, these are things that really vary a lot on case-to-case basis, and really, I think the providers here seeing the children in face-to-face would be able to have a much greater grasp on how to convert that to a clear description of impairment, and what kind of accommodations those would translate to in the school setting.
Okay, we've gotten a few other questions that I can tackle. I have a question here. I have AOA2, so ataxia with oculomotor apraxia type 2. Should my grandchildren be tested for this? So AOA2 is one of our autosomal recessive disorders. So you're affected because you inherited one change from each of your parents. So your children, your children do have a strong possibility of being carriers for this. So it would predispose that your children would have children with someone who's also a carrier. So unlikely, but not impossible. So it would be something that would be definitely worthwhile for your children to meet with a genetic counselor to talk about carrier testing. And so, because there are a lot of different disorders that we can actually do carrier testing for these days besides ataxias. So it's a good idea for anybody thinking about having children to have the chance to meet with a genetic counselor to talk about things like cystic fibrosis and spinal muscular atrophy and all these other disorders that we can screen for prenatally. Let's see, and here also talking about genetics, there's a question about someone whose brother who has RSACs, ataxia, and he has a son who's 10, and I think from the question the son is also affected by ataxia. But again, RSACs is an autosomal recessive ataxia, so if that's really what he has, it would be unlikely that his son is affected unless he happened to marry a carrier. So in a question like this, I'd always want to regroup and make sure that we were very certain of the diagnosis. And there's a question about iron levels, or could that be part of the disease? So I'm not specifically aware of low iron levels being a concern in RSACs, but speaking of iron levels, we know that sleep disturbances are very common with many of our ataxias, and so for some people, if their iron stores are low, they'll benefit from supplementing those. So definitely there's a lot about the metabolism of iron that we don't fully understand. And we also know that, for example, with Friedreich's ataxia, iron is very important in the pathophysiology and in its role in the mitochondria. So iron is definitely an important player and something we should be paying attention to for sure. And then there's a second part to the question, which is a very important question. Any resources for families who do not have the money to do the genetic testing? So this is where it's super important to work closely with a genetic counselor to explore all of the options for obtaining this testing. And this, depending on the situation, it's definitely easier, at least in the United States, for children to get genetic testing done. Sometimes for older people, especially when they have just Medicare insurance, it can be very challenging to get it covered. But especially with children, we're generally very successful. We spend a lot of time arguing and discussing with insurance companies why they should pay for this testing and why it's important to get a diagnosis and how it might impact management. And so I'd say definitely having a doctor and a genetic counselor who are on the ball in terms of exploring all the options to get it covered. There are definitely some options depending on the testing company, of self-pay options that might be feasible, and many of the companies have sliding scales available based on income. So it's just something we need to explore all the options.
Great. So is that all the questions that we had submitted?
Oh, let's see. Here we have a question about, sounds like someone whose daughter was just diagnosed with episodic ataxia type 1. Sounds like she does have some seizures associated with this, but she's doing well on zonisamide, but having issues with weight gain. And so we know that for zonisamide, suppressing appetite is a super common side effect. And so in general, whenever we're working with medications to address ataxia symptoms, we're always weighing benefits versus side effects. And so if this might be a situation where you may want to talk with your neurologist about your concerns about weight and appetite and consider transitioning over to a different medication if you feel that the side effects are outweighing the benefits.
Excellent. Thank you, Dr. Baranano and Dr. Chin. That's all we have time for today. As a reminder, a recording of today's webinar will be made available. And thank you all again so much for joining today's webinar.
Great. It was a pleasure. Thanks so much for having us on, and for everyone who took the time to join us.
Yes, thank you.